When I found out I was giving this presentation, I reached out to some of the OB residents, and we all know I have a great relationship with you guys because of previous residents that were here. So they all gave me feedback that they wanted to know more about our NICU consult process and how we go about doing it. And so I tried to look up your board specs to see what are some board topics that would be relevant for you guys for me to present. But when I looked at it, there was nothing available. So this is really just for your guys' own education, which I think is great. And I think that's how we can build bridges between our two specialties. And so with that, I'm really excited to give this presentation to you guys. So I had to sign this financial disclosure statement. I don't have any, but wish I did. Now it's not letting me go to the next screen. Oh, there it is. Yep, see, really wish I had some. All right, so my topic of my outline, I'm gonna start with a case presentation. I'm gonna talk about how we go through our NICU consultation process. I'm gonna pose questions to both sides just to kind of get us to a consensus about things and just kind of get our minds thinking. And then try to pose a future model for how we can go about this in the future. So, case is gonna start. Mom is a G5P1303. She, on this day, was 23-0 based on a second trimester ultrasound in which she was told her estimated due date was 12/16/20. She had late prenatal care and was admitted for asymptomatic severe range blood pressures. Of note, I'm not gonna read all of this, she was positive for trichomonas and HSV1. She had a history of chronic hypertension for which she was not taking medicines for because they said it made her headaches worse. She also had a history of pre-E in which ended in an infant demise. And then she was a birth historian. So from that history, you guys admitted her. She got her routine labs. You guys also did help labs and got a UDS. All of which was negative. And then you did a point of care ultrasound, which told us that there was an estimated fetal weight of 529 grams, and there was oligohydramnios. And so she was admitted, got magnesium, started on steroids, was given hydralazine, labetalol, both IV and PO, and was started on Flagyl. And then it says in the note that NICU will be consulted the next morning. And so when we consulted the next morning, all we know is that the fetal weight is 529 grams and that mom is really, really sick. So when we do a consult, we kind of talk about all of these things. So the NICDH calculator, which helps give us some statistics. In our minds, we may be thinking about IVH, which is intraventricular hemorrhage, ROP, neck, blood pressures, lines, feeds, and then we go over the whole overall course with the parents. And my presentation might seem lengthy, of which we do not necessarily give to the parents, but just kind of wanted to have everything in here for your completeness and understanding. So first question we normally get asked by the parents is my baby going to live? The short answer to that is we don't know. We don't have an 8-ball that helps predict their future, but this NICDH calculator, NICHD calculator helps us predict or helps give statistics and outcomes for the parents. So one kind of caution I want to say about this data is that it is data from 2006 and 2016 from the Bond Network. And so this data already is about 10 years old. And so the percentages that it gives might not be completely accurate to today's, to what we know about today, since centers are now delivering newborns that are of lower gestational age, like 22 to 23 weeks. And we know that data from IO, which they published in the Journal of Peds in February 2020, we know that they're one of the best centers for peri-viable birth and outcomes. They just published that their survival to discharge for 22 to 23 years is about 78%. So I don't know what our data is right now, but I know we're not there, but we have room to grow and improve. So the first set of statistics it gives me for that 529, if we know that it's a single birth, it's a male, and that we only have, and we'll have a complete dose of steroids, it gives us about survival to discharge percentage of 33%. And so that range overall is 21 to 47%. And then gives us statistics on what their outcomes are going to be. Most likely going to have a moderate to severe neurodevelopmental impairment with some sort of cognitive delay and maybe like a lower percentage of like moderate to severe cerebral palsy. So while the statistics don't always help us, and so what we know from the, so then an ultrasound was given the next day, and all I wanted to show was that now with a more accurate weight from a more accurate ultrasound, it's lower, which changes our percentage by about 10%. And so while the statistics don't always help us tremendously, and it doesn't always help parents, and they don't always understand what we're saying when we do it, I think it just gives us a good starting place of where to go from. So most of our presentation is focused on the delivery room and if their child is going to make it out. Because we know that if they're not going to make it out of the delivery room, there's not really much else to go from there. So where in the delivery room, you know, seconds to minutes matter. And so not having all the equipment available to us can make a life or death situation even more that real. So I just wanted to go over really quickly what all is needed. It's really important for the heat to be on the bed because a cold baby doesn't perfuse as well. It's harder to resuscitate and just takes us longer to get through the process. So, and makes for worse outcomes. And so it's really important to have a stethoscope, to have intubation supplies such as ET tube and multiple different size blades, suction equipment, this is suction equipment, OG. We have our Neo Puff up there, which helps us bag the baby. We wrap anything less than 28 weeks in a plastic wrap to help keep their heat inside. We need to have the code cart available, which normally has the umbilical catheter tray and the lines available in case, you know, the resuscitation is going south and we have to put in urgent lines for code dose drugs. Also a transformer, again, to just help keep the baby's temperature up, and then leads and pulse ox equipment so that we can accurately know what's happening. But however, the most important thing that's going to tell us what our baby is doing is the stethoscope, because we can listen to the heart rate. Moving on, the first topic that we're thinking about with the parents is intraventricular hemorrhage. And so pretty much with all of these outcomes, the smaller they are by weight and lower the gestational age, the higher the risk of this outcome that could occur. And so how this happens is the germinal matrix inside the brain is a highly active center which produces new brain cells and therefore requires a rich blood supply, making it susceptible to injury. So most of these bleeds occur within the first 3 days, with 90% occurring by 10 days of life. So some event occurs which creates a hypoxic ischemic insult, which injures the capillaries and the germinal matrix. And then you have an increase in cerebral blood flow with treatment, causing reperfusion of the injured vessels, leading to bleeding, eventually leading to germinal matrix hemorrhage, and then to the intraventricular hemorrhage. And so, like I said, we don't necessarily tell them all of this, but I'm just providing this extra information for your guys' learning. So there's a grading system, grade 1 to 4, 4 being the worst, and just wanted to provide you guys the least clinically significant to the most clinically significant. So grade 1, you can see this is where the germinal matrix is. There's a little bleed here. And then on imaging, you can see bright is where the blood is. So up to a grade 4, it's just diffuse bleeding throughout. And this is just through the ventricle. You can see that that the ventricle is also dilated and that the bleeding has extended into the interparenchymal area. So outcomes for grade 1 or 2 IVH increase the risk of disability. 23% of survivors with a grade 3 IVH developed cerebral palsy, compared with 17% of those who had a grade 2, and only 7% of those who had a grade 1. 50% of survivors with grade 3 had definite neurologic consequences. And so what we can do to prevent this, so antenatal steroids are going to be our best mode of defense. And I have another slide, we'll talk about that a little bit later. Magnesium sulfate, it does help improve neurological outcomes. How it does this, we're not exactly sure, from what I was reading in the OB consensus. And so other things we try to do down in the NICU is what's called a golden hour. And so from admission to the time we have lines done, labs in, baby on the ventilator, we close the top to try to make it more like a womb-like environment to provide as little stimulation as possible. We want all of that to happen within an hour. It's an arduous task, but we try to make it happen. Delayed cord clamping has also been shown to reduce the incidence of IVH because it helps give some extra blood volume to the baby, kind of to help keep their blood volume up. And however, that delayed cord clamping scenario with peri-viable birth is not, could not be facilitated at our center at this time. We just don't have the space or availability or the equipment to really do that at this time. And then how we kind of follow up these babies is we have a cranial ultrasound screening program in which we screen everybody that's less than 30 weeks at 10 days of life and 30 days of life, and sooner if needed. The importance of steroids. And so just to compare baby, we can see that with steroids, we had a 33% average survival. And with no steroids, it brings our chance of survival down to 20%. And so steroids, like, not only do they help with IVH and improve neurological outcomes, it also helps us strengthen the vasculature and strengthen the skin architecture, which helps us maintain their electrolytes and helps them maintain the heat. And then it also helps regulate the blood pressure, which also helps prevent IVH. So moving on, another big outcome we look at is retinopathy of prematurity, or ROP. So it's a disorder of the developing retina in which you can see this line of demarcation where basically the vessels stop growing, and eventually it gets bad enough to where it leads to complete retinal detachment. And so we try to do strategies to help improve that while they're in the NICU. So we start screening with birth weights of less than 1,500, or if they have a gestational age less than 30 weeks, or if we have other infants that are a little older or of a bigger weight that had some kind of unstable course. And so other outcomes we should be aware of is that even though they might not develop ROP, they are at higher risk for visual disorders such as strabismus, amblyopia, high refractive errors, cataracts, and so forth. And so it's really important for them to get ophthalmology follow-up at 4 to 6 months after discharge. So I think one of the biggest known outcomes or risk is neck or necrotizing enterocolitis, which is an ischemic necrosis of an intestinal mucosa. It has increased incidence with lower gestational age and birth weight. But even though we know it's more prevalent in the premature babies, we still know that about 13% of cases occur in infants. And typically this happens in concert with i.e. sepsis or rage. And so neck typically occurs and colon, which are the most common sites. You can see on this X-ray that there's just fine lucency bubbles everywhere. It looks better on my screen at home. I guess it's just a bad picture. So it's great. But then you can also see that there's just air within the and eventually it's the concentration is really unstable baby. How we prevent this? So one of the best known factors is, again, antenatal steroids, which again helps stabilize all the vasculature and prevent ischemic events. And then breast milk has been shown to greatly reduce the risk of neck. It helps stimulate the mucosal defense system and gives moms antibodies to baby for protection, since babies are they have an immature immune system, so can't fight infections on their own. But so we ask that parents, if they're not willing to provide breast milk or unable to pump breast milk, we ask them to provide donor consent if they're not able to pump, like I said. And so I think it's really important just at this time, take a moment and just say that parents feel very helpless when their baby's in the NICU. There's not much they can do. They're, as described in a book we're reading right now, it's like an alien inside a really unknown world in their little incubator or space capsule, I think the author puts. And so I think that we should just try to empower the parents to breastfeed as best they can, encourage them to pump, say they're doing a good job, just because this is like the one thing that they can do for their baby while they're in the NICU. So another thing we normally discuss with the parents are lines and procedures that could possibly happen. So the intubation typically happens in the delivery room. Umbilical lines will happen downstairs most of the time. And so all we really say about that is that umbilical lines just help give their baby nutrition since they can't feed by mouth at this point in their life. And sometimes we have to put in chest tubes. However, with antenatal steroids and board, it has greatly reduced the risk of RDS. And so luckily we've had to put in less chest tubes as the years go on. So sometimes if there's time during the consult process, we talk about the overall course of the child in the NICU. And so like I said, most of our consult process focuses on the delivery room and the resuscitation process. But then if we have time, we can talk about this honeymoon phase where it seems like they're really stable and doing great. And then they have this 2-week dwindle, as it gets called, where they just have some sort of overboard, and they just have like a rapid decompensation. Then eventually they overcome that, get to some kind of growing and feeding status. And overall, we like to tell the parents, because they always want to know when they're going to get out of the NICU, we tell them that they're at least going to be there till their estimated delivery day, if not a few weeks before, maybe a few weeks later, depending on what happens during their course. We also have to remember that every baby's different and that the birth weight is just as important as the gestational age. And so from the consultation we have with the parents, one of the most important factors we do is just we want to know what outcomes and what's meaningful to them throughout the process. So we can just make sure that we're tailoring our care to meet their needs. Also with this, there's so many support groups out there that if we aren't willing to provide what they want, the parents can go out there and find elsewhere what they want. So just really important to have this conversation off of that. So after the consult's over, we write this report, and which just gives us kind of a summary of mom's history, a generalized overview of our discussion with the parents, and specific, instructions for what we wanted to do and what the outcomes we wanted to talk about with the family. And so in this specific case, we just talked about that we wouldn't perform CPR, but that we would offer like code drugs like epi to help the baby's heart and help them get out of the delivery room. And so I was wondering from you guys, from the OB side of things, if there was anything else in the note that you guys think would help you guys in your decision making. So back to the case. So after we did our consult, they get ultrasound the next day, which changes our estimated fetal weight to 453 grams. And now we know that there's an absent end diastolic flow in the umbilical artery and a possible pericardial effusion with cardiomegaly. Recommendations for this are just to get twice weekly BPPs with umbilical artery Dopplers and a fetal echo. So over the next few days, the steroids get completed, yay for us. Mom also completes a course of magnesium. However, her blood pressures remain uncontrolled. Multiple PRNs are given, and there's increased dosing of the long-acting medications, and more agents are being added. Torch labs are also collected, which were all negative, but mom's clearly pretty sick. Day 6, we finally get a fetal echo, and so we see that based on echo that there's a flow reversal noted in the right pulmonary vein, the ductus arteriosus, the transverse arch, and now they note diastolic flow reversal in the umbilical artery. Structurally normal heart overall, which is good, but obviously baby is under some sort of stress, most likely from placental insufficiency due to the hypertension.
Jess, do you want to explain to them what that means?
And so moving on to day 7, there was an update noted in the chart in which outside record from the hospital, from the outside provider, and now the estimated delivery date is actually a week later, making the kid a week younger. And so now, instead of her being 23 and 6 on this day 7 of mom's admission to the hospital, she's just now 23 and 1. And so that detailed ultrasound was actually done at 22 and 4. on the fetus. And so, which moves the baby's weight in the 36th percentile is good for the baby, means it's not IUGR anymore, but kind of just changes things. And so this just, I included this chart again, just to show now that we're at 22 weeks, how that would have changed our consult from a 35% range of survival to now moving back to 21%. So then there was a BPP done that morning as well, which also showed that there was reversal of the diastolic flow in the umbilical artery, that there was reversal of the A wave in the ductus venosus, and now the baby is at increased risk for uterine death. So then the decision is made to deliver on day 7 at 3:05 at the afternoon. They had a level 2 section and said that the reason for delivery was based on the echo results in combination with mom's preeclampsia. In the op note, it was noted that there was lots of adhesions, took a while to get the baby out. And then fluid is noted to be dark yellow, which I'm assuming is consistent with like meconium or some kind of an infection was going on. There was a nuchal ×1 around the baby too. So the placental pathology showed that there was a placental infarct of the hypertensive type. And so I just included these pictures because I wanted to know if that looked like a certain way on the placenta. And so this is an acute infarct, chronic infarct, and this is a hemorrhagic necrosis of the placenta. So in case that comes up on your words, you heard it from me. Just kidding. And so birth, where this puts us is baby came out was 520 grams. Mom had steroids, was 23 weeks, and that puts our percentage around 32%. And so moving on to resuscitation, baby was pretty sick when it came out. ABGARs were only 1 and 2 at 1 and 5 minutes of life. Baby required PPV of 100%. And it was intubated on the first attempt by about 2.5 minutes of life. 1 dose of epi was given via the ATT tube for a heart rate less than 60. And at that time, the NICU team left at 8 minutes of life, just because baby was very unstable and they wanted to get it downstairs as soon as possible to stabilize. And then from this, there is also no cord gases present in the chart that I could find. On admission to the NICU, lines were placed. This is our admission film. You can see baby's lungs are not great, just severe RDS, and that tube is a little deep, so that was pulled back. On this one, you can see lines were placed, and cure strips given, labs were drawn. We had to give blood because our first CBC that came back only had a crit of 21, and we liked our crits to be somewhere at least above 40 would be great. And our admission gas was 708, 62, 46, 18 with a negative 11 and a lac. So our baby came down pretty sick. We also got a cranial ultrasound on admission, which showed that the baby already had bilateral grade 3s with the left worse than the right. You can see that there's bleed, there's dilation of the ventricles and extension into the ventricles of the bleed. So more to the baby's course. So after the admission day, the next day, baby developed anuria along with hyperglycemia, requiring an insulin drip. The next day, her mean blood pressure started decreasing. Was started on dopamine and norepinephrine. We gave another dose of Curosurf. We switched her onto an oscillator. Also switched her antibiotics to cefepime, just for better coverage, and she was neutropenic at the time. Tried to give another dose of Lasix for the anuria, again with no response in urine output. Nephrology was consulted, but didn't really have much more to offer. It's really hard to put in a dialysis catheter in a 500-gram baby. And more platelets and blood products were given. On day of 3, a second dose of Lasix was given, again for anuria with no response. Hydrocortisone was also started for adrenal insult. And we obtained a renal ultrasound at this time that showed no anatomical abnormalities, but also noted that there was no urine in the bladder. And so on day of life 4, after talking with mom and telling them about the grave outcome this baby was probably going to face, that they decided to politely withdraw care on baby, and the parents also declined an autopsy. And so Now I just want to open up the floor to discussion just because I think this case was pretty hard on both sides. Mom wasn't the best historian, and so that doesn't really help us. And then both parties were like very sick. Oh, sorry. We're very sick. And so I think this kind of left us with questions of what went into the decision making for timing of the cesarean section. And so when I was trying to read up on the OB literature, I reached out to my friend in Houston, who used to be a resident here and is now an MFM fellow, who gave me some papers to read. And so the first one I read was the obstetric consensus from 2017, which basically said that they would not have recommended cesarean delivery for fetal indication until 25 weeks of life. However, in another paper from a joint task force between SMFM, the AAP, and ACOG from 2014, they recommended that a cesarean delivery could be done for fetal indication at 23 and 0. So it just seems like there's lots of variability among the literature. And so I was just wondering from the OB perspective, kind of what all went into the decision to call that.
If that feedback will stop, maybe. Yeah, we can hear you.
Can you?
Yes, sir.
Okay. First of all, I would like to congratulate our neonatal fellow for an excellent presentation, because these are the things that don't get covered enough in the decision-making process when you're confronted with a baby that's in the paraviable status. And all residents should be at least aware of the steps that the neonatal service goes through and what the patients are told, so there's consistency in what they hear from both sides of the fence, so to speak. I think one of the problems with a case like this is that you have a baby that, if nothing is done, given the fetal assessment that was being made with the oligohydramnios, the abnormal Doppler studies, if nothing is done, this is a stillbirth. So that's the other option. And I think that when you look at a case like this, it's a difficult case because of the numbers are not in favor of this child. And one of the things that strikes me about what was done to this baby in the 3 to 4 days of life is a very intensive care approach, which also is a very expensive approach. And because these are things that you don't know what the outcome is going to be, but you do know how much it's going to cost. And I think that's something that should be at least brought up. Patients don't think about that under these circumstances, but I think it would be helpful to know what the average cost per day of NICU care is and how it's paid for. Because if a certain person wins the presidential election and there's Medicare for everybody, taxpayers are going to be slugged right and left with expensive admissions and expensive care. So maybe I would like to hear what the cost of this child's care is and what the average cost is per day of NICU.
Also, Connor,
Answer.
Yeah, we're not being able to hear the response, unfortunately.
So hey, it's Paul, man.
Hey,
The average cost is probably about $10,000 to $15,000 a day. When you look at a cost analysis of NICU care, overall the cost of neonatal care in the United States runs about $15 to $20 billion a year. It's been repeatedly shown again to be one of the most cost-effective, if not the most cost-effective of all intensive care that we provide and of all patient care that we provide. Babies that die like this are a small fraction of that cost because they actually don't survive very long or consume all that many resources. So I've never found resource arguments as a compelling reason not to provide active management for babies at 20, 22, 23, 24 weeks. because there's not that much cost savings. Most of the babies that are going to die early in that time course, and not be a significant expenditure on our U.S. healthcare dollars. We spend more by far, like 3 times as much on wine and other things in the U.S. each year than we spend on neonatal care. So it's really a pretty small fraction of the care that we provide.
Thanks for those comments on both sides. I'll just say that it's very difficult for from an obstetrician side to have in this decision-making tree because of the contradictory evidence or the contradictory recommendations or guidelines, however you want to look at it. But at the threshold of viability, which is kind of a moving target depending on where you are, what the data is in the place where you're working. There are some difficulties with that because the NICHD, SMFM, and ACOG sort of guidelines do favor that you should do more than less at earlier gestational ages. And several years ago, it was had a little more conflict built in. It does appear that there could be some state, individual state legal ramifications for both obstetricians not doing their job as the state sees it with regards to the threshold for viability. And the same goes for neonatal resuscitation. So it's also important, perhaps, and maybe Dr. Mann make a comment about it, because the ethics side and the legal side in some states perhaps are in conflict. I've always found it to be that if it's kind of a damned if you do, damned if you don't situation, especially for cesarean sections for 23-week babies, while you understand what the risk is, and it's not just the risk for delivery of a baby that is, by a cesarean section to the mom, but it's significantly ramped up risk because that's a classical cesarean section, which also inherently has more complications, perhaps, and more risk and implications for future fertility. So I think, to ask the question, what went into the delivery of this baby? I don't think I delivered this baby, but I know that there's a lot of conflict amongst ourselves, even with the idea that this is something that is in the cards, and that's really shared decision making with the best information that you have, understanding that this was going to be a stillbirth in the incubator that was the mom, and perhaps the chance of survival in the NICU is perhaps better. So those are my comments. Anyone else have any comments?
One of the things, Dr. Red, I'd say briefly about that is that, one of the things that it's interesting, when I attended the perinatology conference in Iowa, Dr. Gancar presented some of the statistics for their survival at 22 and 23 weeks, is they do not do C-sections before 24 weeks. And the reason for that is they've had a number of moms that have come back from classic C-section with complications and other pregnancies, including uterine rupture and other significant issues. And so they've made that decision that that's not on the table until they get to be 24 weeks corrected gestational age. And I think that's the sort of thing that we need to continue to evaluate, because you're right. I think from an ethical standpoint, or at least from a parent pressure standpoint, what we're seeing more and more is it's pressure for parents to provide active management at 20 weeks. There's plenty of social media pressure. Doesn't take long on Twitter to find your 22-week support group that shows all the hospitals in the U.S. that are 22-week friendly. And, as we think through what our institutional practice is, doesn't necessarily mean we have to cave to that sort of pressure. I think what we need to think through is, what are our goals, or how do we get the best outcome for both the baby and the mom? And for some situations, that's probably, to me, maybe earlier delivery than we're doing right now before babies get more stressed in utero. I think in other situations, maybe later delivery to what we're doing right now, that we're not going to choose to try to rescue and do a cesarean, classic cesarean section on a 23-weeker because we don't think that the risk to the mom make that worth the, chance of survival for the baby. So I think it is very complicated, and that's why I think Dr. Gancar's talk to me is an opportunity for us to continue to have good dialogue and for us to think as a group, how do we provide best outcome for mom and best outcome for baby?
Thank you very much for those comments. They are very well taken. You know, my senior project when I graduated residency was to look at, survival at the threshold of viability, which included delivery mode, which at the time it was controversial whether you would deliver these breech babies vaginally or by cesarean section. And so what came out of that was these babies were going to be delivered by cesarean section based on evidence. And we started doing cesarean sections earlier and earlier and earlier. My problem, or my comment, I should say, is that the difference between a 23-week and 6-day baby and 24-week and 0-day baby is impossible to determine, perhaps in utero, but also the fact that either way, mom's getting a classical cesarean section if she makes it one more day. So the idea that you wouldn't do cesarean sections at a certain gestational age because of that is very difficult without a very clear shared decision-making model to maybe take into consideration the fact that the parents are going to have that pressure and the regret of one day from that decision-making may be very difficult. So it just highlights how complicated this threshold for viability is. So again, thank you for your comments. I think we all need to really process this and then take it on a case-by-case basis, unless we should get together and have a more formalized approach that says we will not do cesarean sections, at a certain gestational age, which right now that target, if I'm not mistaken, is less than 23 weeks.
Yeah, can you hear me? I'm in the car.
Yes, we can hear you.
Excellent. Yeah, thank you so much again for this presentation. Obviously important for both services here. Yeah, full disclosure, I come from a place, another institution, where we did set hard boundaries. We didn't resuscitate less than 23 weeks, and we would never consider a C-section for less than 24. And boundaries were hard. We didn't, 23 and 6, we'll consider it type of a thing. I guess my question is, for parents that are put in the unenviable position of making this decision, for this institution, where does the rights of the parents for deciding resuscitation of an infant and the rights of the infant to be resuscitated, I guess, where do those 2 points meet for this institution and decision making?
I would say on that, we utilize a shared decision-making model with the family. I think as a neonatal group, we've come to the place probably in my 4 years here of accepting that most parents will want us to resuscitate at 22 weeks. And we see that this is not a situation of medical futility. There are plenty of examples of survivors in the literature. And, where I trained as a fellow at Iowa, that's about a coin flip now for their 22-weekers, about 50% to 60% survival. There's a lot that goes into that. In the way that an institution supports babies at those gestational ages. I also don't think that you can take one hospital's population and transplant it to another hospital and expect the same outcomes. So that being said, I still think it's important to have a conversation and to try to understand parents if there's hesitation to resuscitation, what that hesitation is, or if it's that they want us to provide, a trial of therapy, then, that's a reasonable ethical approach. Because again, we know that most 22-weekers who are not going to survive will not survive early. Many of them will not survive the delivery rate. So it's not back to Dr. DeVoe's point, a tremendous expenditure of healthcare resources to support 22-weekers. They either have the lung maturity that they need or they don't have the lung maturity that they need typically. And so, parents, parents are.
So I guess better stated, if say there's a 23 and 5 delivery and the parents state, I only want supportive care or comfort care. I prefer not to accept the risks of a non-intact survival. Is that acceptable, I guess, is the question.
It's acceptable. It's a challenge, I would say. I would say certainly we as an institution have never said formally we're going to resuscitate every baby at 24 weeks. For example, that's where a lot of institutions have done that. I think my goal has always been that we reflect national norms. And national norms, when you look at ACOG and the AAP, when they got together and convened and talked about this, would say the parents still get a choice at 23 weeks. And that's where I feel like we are within our institution. So if the family said to us that we are not comfortable resuscitating a baby at 23 weeks and 5, we prefer comfort care, that's something that I think from an ethical standpoint and institutional standpoint, we should support.
All right, my other question would be, has anybody been working on institution-specific statistics for counseling in our population?
We have them somewhat from the Vermont Oxford Network data. That's one of the things that I think we need to continue to get better at, is to give you all the feedback of what the neonatal data looks like at our institution, because I do think, again, that becomes a very important part of our counseling. It's fine to have the national statistics and to look at what the some of the best centers in quotes have as far as their survival, but then it's equally important for us to know what our local data is. And I don't think historically we've done a very good job as a neonatal group of providing that data to you, so that you can help have an enriched conversation with your OB patients.
Hey, can I make a point? I'm a fetal cardiologist, Dr. Shivram.
Yes, please.
Yeah. So I was listening to the whole talk, and the decision for delivery was made because of the fetal echocardiogram, as it was mentioned. I believe that meant that there were abnormal Dopplers on the fetal echocardiogram, because I did review the fetal echo and there was no cardiac dysfunction, no high drops, no congenital heart disease, or there was any indication from a fetal standpoint that this baby had to be delivered. It was because of the severe placental insufficiency we had observed that there were reversal of flows in the transverse pulmonary veins, which would have caused some diastolic dysfunction, obviously, which were not detectable on the fetal echocardiogram. So I'm going to think that the C-section was done because of the maternal reasons.
Dr. DeVoe, you have your hand up.
I'd like to address another point, because the story just begins with neonatal survival, but most people in training don't really see what these children look like, the survivors look like over time. And one of the most important parts of this presentation is looking at handicap that goes on for a lifetime. And one of the things to really think about here when you're discussing these cases with parents is, what is the impact of having a child who's got cerebral palsy, who is blind, who is deaf, that's going to need lifelong care and will never, ever be able to have an independent life outside of that. I think that's an important issue. And that's also an issue of total lifetime expense for caring for such a child. And I've seen these children and patients that I've taken care of and delivered, and it does have a significant impact on family dynamics, particularly if there are other children in the family. So I think that bears some consideration when you're talking about intervention for babies that are on the threshold of survivability.
And I agree. I think that's certainly a part of the conversation. I would, one of the things that I think is helpful when we're discussing this with families who are questioning what they should do is to have an open conversation of, well, what outcomes would they not be willing to accept? Fortunately, the outcome that you described is pretty rare, and we would know that fairly early for most babies. That to have that degree of neurologic injury usually requires pretty significant bilateral grade 4 IVH. And with antenatal steroids being given, we've seen a great reduction in that. I think the story of the neonatal literature with outcomes in the last 15 years has shown continued less babies that have those extreme outcomes. Severe ROP is a pretty unlikely outcome. Maybe 5% of babies would have that degree of visual impact. Certainly the cognitive impacts are there, though. We know that most commonly the only thing that we can predict off of ultrasounds in the NICU or MRIs is cerebral palsy. It's very difficult for us to predict cognitive defects. There's a number of babies that I've taken care of that had bilateral grade 4 IVH that I still get postcards from their parents about how well they're developing. So I think, certainly those are important conversations. And I think that there are families out there that know that they would be unwilling or unable to accommodate a child with disability. And, I think it should be an important part of the prenatal counseling for those children. I think, The vast majority of parents that we counsel here, though, are just focused on one outcome and one outcome alone, and that's survival. And so it's very difficult for us to have that level of enrichment.
Okay, so that was a great discussion, everyone. Good job. Let me go back to our presentation. So all this say, let's work together, which we just modeled. So I think that there's literature out there that shows that creation of a fetal consult program has shown to improve outcomes. Like we all were saying, consistent messages to parents, all parties get on the same page, and we're able to plan and prioritize our needs for our patients. There's an AAP, what's it called, article out there from Jane Cummings, and that was published in 2015, which shows that good communications among healthcare providers promotes optimal decision-making, that normally the perspectives on each side of the delivery room table are different, and so that these differences should be discussed prior to meeting the parents so that we present consistent information, and that it's better to have some discussion with the family rather than none prior to the baby being born. And then from that same obstetric care consensus article, just really quickly, ideally the counseling between OB and NICU teams will occur simultaneously or will occur in such a way that each team keeps the other informed of the content of their discussion, and that these efforts will help to optimize coordination to avoid the provision of conflicting information to the patient and their family, and that it's preferable that institutions develop consensus guidelines regarding counseling about outcomes and a general approach to assessing the periviable newborn, as you guys have already talked about. And then I just kind of wanted to throw this in there. Somebody talked about withholding care, that our decision to withhold care, we need to emphasize that decisions to redirect care do not mean foregoing all care, but instead focusing on palliative care. And I just wanted to say that when we do have to make a decision, or when the decision is made for us, that both sides of the equation do a really good job comforting mom and baby in that process. And so then avenues to impact a big change at our institution, like I said, the creation of a formal fetal MFM consult service. However, we have a long road ahead of us, which will probably take many turns and detours along the way, but there are things that we can do now for better teamwork and communication. So with that, I think that consults are very challenging in general. We see here that there is an opportunity for more exchange of information and ideas prior to a formal consult, and that we are internally revamping our process for consults as well. Deliveries, we want you guys to know that we support you in your decision when we are called to deliveries. We would love to be called ahead of time, but we know that deliveries are unexpected and they don't give us a timeline for when the baby is going to come out. And so, but having us there early allows us to set the bed appropriately and has everybody there at who needs to be there. And then I think that we need to formalize our debriefing process so that it is inclusive of everybody involved. And then I just wanted to also reach out and say that we have NRP simulations with Johnny, who's one of the state coordinators for NRP and Stable, and that if anybody wanted to practice their NRP skills, we have a monthly skill fair, if you will, where you can practice your skills and get more comfortable with it in case of the event that we aren't there on time. Just trying to create bridges. And so I just wanted to say thank you guys for listening, participating in the discussion, and I think that we can continue to work together for the care of mother and baby. That's all.